Dr. Stafford is here for our next lecture. I forgot what her topic is.
Hi there. It's nice to see everyone, or sort of see everyone. I'm going to talk about dementia and barriers to good end of life care for patients with dementia. Do people need to take a little break before I start, or be good to just jump right in?
I think you could jump right in. They get 15 minutes after your lecture before.
Okay. Perfect. All right. Let me share
Thank
my.
you so much for being here and giving this lecture.
Sure. Of course. Share my screen. All right. So I'm Jensy Stafford. I'm the program director of the fellowship at Brown, and I also work for Hope Health, which is a hospice and palliative care organization serving Rhode Island and Southern Massachusetts. It's great to be here with all of you guys today. So we're going to talk about barriers to optimal end-of-life care for patients with advanced dementia. I have no disclosures. So our objectives today. So one, you guys all know this, preaching to the choir here, recognize dementia as a terminal diagnosis, and we can talk a little bit more about what makes a terminal diagnosis. Two, we will explore barriers to end-of-life care, talking about clinician barriers, systems barriers, and caregiver barriers. And finally, we'll try to identify strategies to optimize dementia care. We only have an hour, so we're not going to solve all of the problems, but we'll try to talk a little bit about what kinds of things we see. So we'll start off with a case presentation. So we have a 62-year-old man. He is an artist and a professor, and he has been noticing that he's had short-term memory loss. He'll be giving a lecture and he can't remember the words. His wife will send him with lists of things to do and he forgets where he's going or what he's doing. He's having word finding difficulties. He's gotten lost on the subway. He's been forgetting appointments. So this is Bill. Bill is William Utermohlen, who was an artist based out of Philadelphia, and he was diagnosed with dementia. And when he was diagnosed with dementia, he decided that he wanted to chronicle that using self-portraits. And so peppered throughout this presentation will be some self-portraits. This was the self-portrait that he made right after he received his diagnosis. And as we see some of the other paintings, we'll see how his spatial recognition changed and how his coping skills changed as well. Which brings us to our final objective, which is to appreciate the individual experience of living with dementia through art. I apologize in advance. I'm going to ask for some audience participation when we go through these various self-portraits. You can unmute yourselves when we get to those, and I would appreciate any participation. I think sometimes doing hospice and palliative care, a lot of times when we meet our patients who have dementia, they're past the point of us having a conversation with them. And we don't really get to know what their experience is. We talk to their families, but we don't really get a great sense about what their experience is living with this disease. And so part of this objective is to bring the humanity back to persons who are living with dementia. So this is the first self-portrait that we will look at. This was right after his diagnosis. I'm curious if anybody is willing to volunteer. What kinds of things do you guys see? And don't be shy, I'm good with silence, so. Any takers? All right, seeing none, I will offer my thoughts here.
Actually, people are putting it on the chat.
Oh, people are putting in the chat. Okay, perfect. Yes. Thank you. Thank you. I should have been looking at, I'm like totally dating myself here by not looking at the chat. All right. He has himself in neutral colors. Yeah, absolutely. The color palette that we're seeing here is very, you know, it's not a big palette, right? And what does that mean in terms of how he's coping? Frustration. Yes, I see frustration. He's dealing with a new diagnosis that he doesn't know what to do with. Confusion. Absolutely. This is jarring, right? This diagnosis is jarring. The outside looking in. Yeah. Like, what is that around his face? Is that a window? Is he looking? Is he an observer? Is he watching all of this happen from the outside? And he looks skeptical. Does he believe this? Is this really happening? Is this really true? He definitely looks worried, sad, angry, all of that captured into one self-portrait. So why do we care about this, right? Prevalence of dementia is expected to increase. So today there are 6.7 million people in the US who are living with dementia, and by 2050 that those numbers are expected to increase significantly. And so we're going to see more and more patients with dementia. And I think as palliative care, as we make our way into the hospital, into the home, we're going to see more and more consults coming our way, more people in the home setting, more people in outpatient, more people in the hospital. So this is something that's very important for us to be adept at. So one of the difficulties with dementia is that the trajectory of dementia differs from other illnesses, right? So cancer, I mean, this is obviously like a broad generalization, but cancer usually have somebody who's very high functioning, and then you see a steep decline. And then in a short period of time, it's a predictable sort of approach to death. And for organ system failure, it's a little bit more predictable, right? So they have an acute exacerbation, have a pretty sharp decline, and they come back up, not quite to where their previous baseline was. And this continues for some time until they die. Dementia, though, is all over the place, and this decline happens usually over many, many years. It's very difficult to predict, and every single person sort of presents a little bit differently, and it's not as predictable, which it makes it harder when we're trying to prognosticate and trying to counsel patients and families. So here we have another self-portrait. I'm going to look at the chat now. So if you want to add your thoughts about what kind of changes we're seeing from the last self-portrait. Dark. Yeah, it's very dark. Softer lines, resignation, lost all colors in life, right? The color palette is so interesting here, and the darkness over his face feels like there's some comment on what he's going through. Suffering, right? He clearly is suffering. In the last one, we saw a lot of anger, skepticism, confusion, and here there's a little bit of resignation and acceptance of what's happening to him and the suffering. Decay, yeah, that's great, right? His body is decaying, right? His mind is decaying. And the background is all dark. Image of a skull, thought of death, right? It looks like what he imagines death will be. Separation from the outside world. This is great. Yeah, no, he is here. His face is shrouded in darkness, and that is separate from the other outside world that is full of life. Just makes me feel sad. It makes me feel sad too. Like, it's so, just to think that patient that we meet, this was their story before we met them, right? This is what they had to go through. This was the acceptance and resignation that they had to experience to get to the point when they're sitting in front of us and we're not able to talk to them anymore or have a conversation. So moving on to our first objective, so recognizing dementia as a terminal diagnosis. So we know that dementia is a terminal diagnosis, and the Cascade trial is an older trial, but it is a pretty landmark study that you guys should all be aware of. And in this study, they looked at 323 patients and their healthcare proxies, and it was an 18-month prospective study. A quarter had died by 6 months, and over half had died by 18 months. And so what this study sought to illustrate was what is it about dementia that affects prognosis? What does that look like? What does that time look like? And so what they found was pneumonia. We know that pneumonia is a very common complication of dementia, but what does that mean for an individual person? They found that pneumonia increased mortality. So at a half a year, at 180 days, people that did not have pneumonia had a little over 80% survival rate, where those that had one episode of pneumonia had just over 50% survival. Next, fever. They looked at fever and compared those that had no febrile episode versus those that did. And what they found was that at 180 days, somebody who didn't have a febrile episode had a little over an 80% chance of still being alive at that mark, at that 6-month mark. And those that had a febrile episode, only about 60% were still alive at that point. The next, eating problems. So we know that eating problems are very common in dementia, right? Whether it's aspiration, whether it's choking on food, whether it's pocketing food, difficulties with certain consistencies. Those that did not have an eating problem most of them were still alive at 6 months. But many of those that developed some sort of eating problem, whatever it may be, did not survive as long. And so at 6 months, it was about 60% survival. And at a year, it was only about 40% survival. So when you're seeing patients that have had an episode of pneumonia, or they're having feeding problems, or they're having fevers, those are signs that their survival is going to be less than those that don't have that. Interestingly, most of these healthcare praxis favored comfort, but many of them had not received appropriate prognostic information. So 96%, that's almost everyone, cited comfort as their primary goal, but only 18% had actually received any prognostic information. And obviously there are times where we give prognostic information, or we think we've given prognostic information and it hasn't been received. So our communication skills in palliative care are so important to make sure that we are communicating appropriately, making sure that we're summarizing and that what we have said has been heard, has been received by whoever we're talking to. And interestingly, the healthcare proxies who understood prognosis were much less likely to choose burdensome interventions. So they favored comfort, and if they knew what was going on, what they were getting into, they were much less likely to choose burdensome interventions. And so the burdensome interventions that people did receive in the last 3 months of life, 41% of these patients had a hospitalization, an ER visit, parenteral therapy, or tube feeding. And we know tube feeding is not something that we would ever want to do for our patients with dementia. There was a study actually out of Brown years ago that feeding tube in a patient with dementia only increased the use of restraints. It did not lengthen life. It did not improve comfort. It just increases the use of restraints. So that is not something that we would ever, that is a very burdensome intervention with no benefit and actual harm. So just to recap, so we know that dementia is a life-limiting illness, and it's those known complications, right? Pneumonia, fever, and especially eating problems that significantly affect the prognosis. So when you see those things, know that their prognosis is shortened. And healthcare proxies who overwhelmingly favor comfort, but patients still receive invasive interventions at the end of life, especially when they don't understand what's going on, especially when they don't understand prognosis, they don't understand complications or what to expect. We know what to expect, and our patients and families often don't. And so it is on us, the onus is on us to make sure that we're educating and making sure that they are informed about what's happening. So this is a self-portrait from 1997. Open up the chat again. You guys can offer your thoughts. Confusion, right? Like, what is happening? What is happening to me? Loss, right? Like, seems like he's resigned to loss, right? More color and confusion. Yeah. Any thoughts on what this thing on the right side might be? It is a saw. It is a saw. So William was very distressed to find out that dementia was a clinical diagnosis, and that it was something at that time that you'd have to get an autopsy to truly prove it. And so he was obsessed with this idea of like, oh, like I will, when I die, they will study my brain, and it is a saw to sort of signify that fear and that distress around that. It could be an instrument. Yeah, I guess it's an instrument for further study. But yeah. Yeah, so he was very, very fearful about that and very distressed that that there wasn't like some test that you could do to diagnose this. And this is, you know, back in the 90s. So moving on to our next objective. So we're explore some of the barriers to end of life care, and we'll start off with clinician barriers. And one of the main ones is prognostication. So clinicians are really bad at prognosticating. So their dementia is one of those illnesses where it's not predictable. And so there is a lot of variability about median survival, right? So some people can skip through all of the stages very quickly, and some people are slowly declining over many, many years. And this is often identified as a main barrier to hospice enrollment. So how do we prognosticate? It's hard to prognosticate for patients with dementia. There are some scales out there. So the main one that we use is the FAST scale. I know probably other institutions probably use other things, maybe the global deterioration scale, or maybe the ADEPT calculator, but FAST is what is used by hospice for hospice enrollment. So we will talk about that a little bit. So the FAST scale helps determine hospice eligibility. And this was something that was developed in the 80s by Dr. Reisberg. And this is the inverse of normal childhood development. So if you have children, or if you have nieces or nephews, if you've ever been around kids, some of the last milestones that children achieve are the first milestones to go for somebody who has dementia. And obviously, like, not everybody follows this linear pattern, but you can think about the later stages of dementia. So the first things that a baby does, right? Like hold up their head or smile or sit up and then walk. Those are the things that go at the very end. So it's just a way for us to remember it a little bit more easily, and it'll help you figure out, like, when you see somebody, where they are in terms of their staging. So palliative care consults and goals of care discussions often, unfortunately, only occur when obviously every institution is going to be different, but often occur when somebody has severe dementia. And it's often happening when patients are already hospice eligible, right? So somebody is hospice eligible when they're anywhere in this FAST 7 stage, but certainly at the 7C and beyond, but anytime, anywhere along FAST 7. So it's not just being at FAST 7, they also have to have either a comorbid condition or some other comorbidities that infection, feeding problems, decubitus ulcers. So there's a way that those are the things that somebody would look at when they're determining hospice eligibility. But if they have a comorbidity like COPD, CHF, and they're at FAST 7, then they would be hospice eligible. But primary palliative care. So, obviously there aren't enough of us to be able to see every single patient who has dementia the moment they're diagnosed, right? And so a lot of it should happen with primary palliative care, with their primary care doctor, with their neurologist, whoever is seeing them early on in their disease process. So goals of care discussions really should happen the moment they're diagnosed, and there should be anticipatory guidance. A lot of people get diagnosed with dementia, it doesn't carry that same weight that cancer does. People know, they hear cancer and they have some expectation of what life will be like. But with dementia, it's like, oh, they have a touch of dementia and it's no big deal, because not everyone realizes that dementia is a terminal diagnosis. And we as palliative care should be involved much earlier, right? Much sooner than when hospice is involved, and can help with that continuity and help with that transition to hospice. So to summarize, so we're really bad at prognosticating. We overestimate, underestimate, and think about using the FAST scale, so inverse of normal childhood development, to figure out where they are in their disease process. Obviously, some people can go through some of the stages very quickly, and other people might take quite a bit of time to go through each stage. So just remember that that it is generally the inverse of normal childhood development, but sort of figure out where they fall in between, and then plant the hospice seed early, right? Like make sure that you let them know what is expected as time goes on. I usually will try to talk to people about, there might be a point in time where you're not able to to eat anymore, or tell their family that, and just say, like, they might ask you if you want to put a feeding tube, and just say that is not something that we would recommend. So talk about those things early so it doesn't have to be a crisis decision. Refer to hospice at fast 7, and if they have a poorer prognosis indicator. And then goals of care discussions, as always, again, preach to the choir here, should happen as early as possible. All right, so open up my chat again here. So this was in 1997 again. What kind of changes are you guys noticing? You guys think of the coloring, deterioration, right? Disconfigured asymmetry, right? We can clearly see there's more distortion of facial features, right? Clearly his ability to like spatially understand what's going on with his painting is being affected. Darkness, right? Look at the color palette. It's gray, it's black. And the facial features are distorted, right? Like his nose doesn't look like a nose, right? His head seems very big, and his ear seems very big. You almost wonder, like, what is he hearing? How is he interpreting what he's hearing? Flat, right? Very, very flat. He's going through so many stages, and we saw like anger and confusion before, and then sadness, and now it's almost like this like depression, given up, right? Like he's resigned to what's happening to him, and it's really hard. It's so much less sharp, right? So the features are not as well defined. So next, let's talk about other barriers. So systems barriers, and we'll talk about transitions a little bit. So how often have you guys seen this, right? Somebody's living in a nursing home, a patient with dementia, living with dementia, has an acute illness. There are increased staff requirements. They're worried about what's happening to this patient. They hospitalize the patient. Hospitalization always causes decline in function and cognition, right? They don't really get back to their previous baseline. And then they return to the nursing home, and the cycle starts again. So this study looked at end-of-life transitions among nursing home residents with cognitive issues. And it was a retrospective review of nearly 500,000 nursing home residents. And they looked at transitions in the last 120 days of life. And they defined potentially burdensome transitions as transfer anytime in the last 3 days of life, nursing home discontinuity, which is starting at one nursing home, going to the hospital, and then getting discharged to a different nursing home where they don't know anybody, right? So nursing home discontinuity in the last 3 months of life. And then multiple hospitalizations in the last 3 months, greater than 2 for any reason, or even just 1 with pneumonia, UTI, dehydration, or sepsis. All of those things can affect prognosis. So transitions are pretty common. So almost 1/5 of patients had more than 1 burdensome transition. And that, if you're thinking back to the previous study, with 96% of healthcare proxies overwhelmingly favoring comfort, that's a high number of burdensome transitions. And those that were at highest risk were people who were Hispanic, Black, male, people who did not have advanced directives, and then residents in certain states. So the darker colors are the states that had higher rates of burdensome transition. I find this graphic very interesting, and knowing that all of you are from all over the country, this is a good thing to just keep in mind, just to know what is happening in your state. Obviously, this is a little bit of an older study, but it is a very important study for the care of dementia, of patients with dementia. So transitions are markers of poor end-of-life care. So the more transitions somebody had, the more likely they were to get a feeding tube, which we know is not beneficial, right? It's harmful. ICU stays in the last 30 days of life, more likely to have stage 4 decubitus ulcers. They were also more likely to have late hospice enrollment. Also know hospice use is not optimized in dementia. So we know that there are studies out there that hospice improves care for patients with dementia and their families. And hospice care can actually improve survival for certain illnesses, and is not associated with shortened survival. So a lot of people worry, like, oh, send my loved one to hospice and their life expectancy is going to be shorter. And that has not proven to be true. And hospice is either underutilized, so less than a week before death. So you have somebody who's been living with dementia for many, many, many years, and to only get hospice services less than a week before they die feels like a travesty, or overutilized. So there's a lot, especially recently, a lot of talk about for-profit hospices and not-for-profit hospices, and there's a whole debate raging about enrollment of patients with dementia. So it can be overutilized at times. And there's also a higher rate of disenrollment with a longer enrollment. So people that are on for 4 or 5 months are not disenrolling very much. People that are on for greater than 6 months are often being disenrolled, and disenrollment itself is associated with poor end of life care. So just to recap really quickly, so end of life transitions are very common, even though people favor comfort, and it is a marker of poor end of life care. And hospice use is not optimized. So there's so many things. We had many hours. We could talk a lot more about how that could be better optimized. But there's a lot of work to be done there. So we're in 1998 now. What are y'all seeing? Scared, right? Yeah, I definitely see the fear in his eyes. His eyebrows are there's definite fear there. What is coming? What does the future hold at this point? More distortion, almost bewildered, right? What is happening? Dissociation of the head and brain from the body, right? It's just a head and there's no body. Feels trapped, right? The lines around his face almost feel like he is confined and trapped and he just can't get out. And it really does look like a guillotine. I've actually wondered that myself. Is this supposed to symbolize, again, going back to that idea of the head being cut off, head being cut open, or is it, cutting off the offending part of the body, right? So yeah, that's great insights, guys. So our final barrier that we're going to look at is caregiver barriers. So caregiver burden. So talk about the prevalence and impact of caregiving between dementia and non-dementia caregivers. So caregiving is so hard no matter what you're doing, no matter who you're caring for. But when you're caring for somebody who has dementia, who's not really able to help with their care, that is especially hard, right? And it's more unpredictable. So this study looked at 1,500 caregivers who had done unpaid caregiving in the last year. And what they found was that caregiving in dementia compared to other illnesses, to non-dementia, required more time. The caregivers had more employment problems, and it caused more physical, emotional, and financial strain. And so the blue bar is how much, how much time they had, or how much they had to spend in terms of caring for somebody who had dementia, Alzheimer's, or otherwise. And then the green bar is how much time or percentage of time of activity they'd have to spend for other older people. So clearly across the board, people that are caregiving for dementia have to do much, much more. Caregivers also had increased mortality. So they found that there was a 63% higher mortality risk when the caregiver was an elderly spouse. So it's not just an imagined burden. This is real. There's real harm coming from this. I'm going to stop my share for just a moment. I'm going to show you guys a video about it was a New York Times article and video, and it was a patient's wife, and the patient had developed frontotemporal dementia, and this was a kind of interview or video montage of what the wife was experiencing. So let me just share my screen here.
When we were in the neurologist's office,
Is that
We can
Playing
hear
for
a
you
little bit
guys?
of it.
okay? All right, let me go back. Okay. All right, I'm playing again.
When we were in the neurologist's office, I said to him, what can be done about this? And he said, it's brain atrophy. So I know the word atrophy. That just stopped me cold. After the diagnosis, I cried every day for weeks, and
try
I
again here.
apologized to him for every.
Should be able to see a screen too, so I apologize. Let me see if I can share again. Sorry, there's always technical difficulties. Let's see. It's not letting me do full screen, so I'm gonna
That's fine. See if we can see it now.
yeah.
Everything that I ever perceived, I just apologized a lot. And I told him then, I said, you and I are in this together. I'm not going anywhere. And we'll handle it. So we're a little over 4 years into this, and right now he can't speak virtually, he can't walk, he can't read, he can't write. Of course, as I say to him, the man has no stress. Now, do I want to change places with him? No, but the man has no stress. How much I have let go of the people that I once knew. But that's okay because he's the Michael that I know now. Huh? It's just all there is now is a love. There's no real doing. It's just a loving relationship. The time that I really treasure is when he and I take naps together. That's actually just like it was before. You know, we were just cuddling in. And I guess it's a time where then I really don't notice that there is a problem. It's just me and Michael. I feel fortunate that in this life, I have had the marriage that I dreamed of having.
It's a tough thing to watch, I think. Do you have any thoughts after that video? A hard one to watch, I think. So this was a quote from the article. The physical demands on her became daunting. Streets she had thought flat revealed themselves to be hills. Potholes yawned like chasms. She injured her wrist, developed a stomach ulcer, and lost so much weight that people worried about her. She would sometimes wake up in a pool of urine. She had hoped to keep him alone until the end. This thing is going to kill both of us, and I don't know who's going first. I actually just I have a patient right now who has early onset Alzheimer's, and her husband was saying almost exactly the same thing to me, that he thought just the caregiving itself was going to kill him, and how hard it is. So I think as you see your patients who have dementia and you see their caregivers, acknowledge how hard that is. Check in with them, see what kind of supports they might need, see what kind of supports your community might have for caregivers. The organization I work for has a support group for caregivers of people with dementia. And so there might be community resources like that where you live. But I would check that out and make sure to acknowledge how difficult it is, and do all the things that you guys are already doing when you're seeing your patients. So to recap, caregiving in dementia poses unique challenges. Caregivers experience more physical, emotional, and financial strain, and they have a higher mortality rate than non-caregivers. So remember that as you're seeing those caregivers. This is 1999, so very different from our previous self-portraits. What do you guys see here? Feeling of nothingness, right? This feels empty. This feels like nothing and loneliness, loss of identity, right? There's it's hard to tell what features we're looking at. Involution, I love that. It's hard to know what we're looking at, right? Is it a face? Is that an ear? Is that a nose? Maybe there's some semblance of an eye. And yeah, approximately face-like, right? It doesn't look like a real face anymore. So it really gives a sense in terms of how much of a decline he's had, and blah. Yeah, that's how I feel looking at this, right? It feels empty, feels like nothingness and blah. So finally, let's talk very briefly about how to identify strategies to optimize dementia care. So overcoming clinician barriers. So early palliative care and primary palliative care is really important. So making sure that we are getting involved as early as possible, but then also teaching our colleagues to do primary palliative care. My organization actually does like a communication workshop for providers in the community. So we have all primary care doctors coming through to do communication workshops, just to arm them with the basic skills to have goals of care discussions, referring to hospice when it's appropriate, right? So when we start seeing those that decline when people are no longer ambulatory. They're not verbalizing. Maybe it's just one word, maybe it's no words, maybe it's a couple of words. They're not able to do their own toileting or ADLs. They need assistance with everything. They're not walking anymore. Those are signs that it's probably time to refer to hospice. Recognizing bias and inequity, right? We know that hospice is underutilized by minority populations. And so community outreach, thinking about how we can educate and reach our community better. I wish we had so much time to talk about this because it's such an important topic, especially with dementia. There's so much that we could be doing, so much more that we could be doing to recognize that bias and inequity that exists in dementia and across the board with all serious illness. Collaboration, right? Working with, partnering with the geriatricians in your community, the social workers, the neurologists, like making sure that we're developing those relationships early on. So then they recognize the importance of involving palliative care early. And so working together as a team to make sure that we're doing the right thing for our patients. And then as always, research. So overcoming systems barriers, right? Avoid transitions, right? How do we avoid transitions? If we can discuss trajectories, so when we're going to do goals of care discussions, it's not just about code status, right? We need to talk about what is coming as time goes on and how do we respond to that? So it doesn't turn into like something that we're trying to resolve in a crisis situation, which never goes well when we're trying to make decisions in a crisis situation. More palliative care at home and in the nursing home so that we're doing goal-driven care in their place of residence and doing symptom management. So they're not coming in for, oh, they're having a little bit more pain. Let's send them to the ER. No, let's try to manage that as well as we can in their home. And then health policy change. The hardest thing is, when somebody is, if they have Medicare, they're in a nursing home. They elect for hospice. So they'll, the hospice benefit will be covered, but then they're paying for room and board. And really, like if I could change one thing in the world, it would be that policy change. So broadening access to hospice, and then also like the 6-month life expectancy doesn't really make sense for dementia. People who have dementia need that care for much, much longer, but there needs to be so much work on a policy level to make sure that we try to address that. And then overcoming caregiver burden barriers, supporting our caregivers, educating them about what to expect, involving early palliative care or primary palliative care earlier hospice referrals. So like a lot of those referrals are happening the last week of life, and it really should happen sooner than that. And then the respite, hospice is a respite benefit. So if somebody's on a hospice and they need caregiver rest, they're allowed to have somebody go to a facility for 5 days to give the caregiver a rest from that. And then involving the interdisciplinary team. I think I would not be able to do what I do without the help of our social workers or chaplains or nurses or CNAs. Like everybody's working together to make sure that we're providing the best possible care. And so in summary, yes, somebody just commented reimbursement dictates care, which is the unfortunate part of how this all works, right? Insurance will cover things that don't necessarily make sense for somebody at the end of life, but things like providing more support for somebody who has dementia doesn't happen in the same way. So in summary, dementia is a life-limiting illness with increasing prevalence, right, as our population ages. Illness trajectory is key in counseling, right? So a lot of times people don't know what's coming, and we do know what's coming somewhat, right? We have a sense of the changes that we will see as time goes on. So we need to make sure we're communicating that to our patients and family. Well, patients early on, but mostly our families. Avoid transitions when possible, right? Whether it's going to the hospital, whether it's doing any of those like transitions that could possibly equal poor care, because it does equal poor quality of care. And then remembering that dementia caregivers have more strain and higher mortality. So make sure that we're thinking about our patients, but we're also thinking about their caregivers and their loved ones too, supporting and educating as much as possible. And so this was a picture of our artist in the year 2000. He actually lived, this was the last self-portrait that he made. And he lived for 7 years beyond this. And so that's it. Any questions or comments? We have a question here or a comment here. If a service gets generously reimbursed, patients will get it, sometimes even excessively or inappropriately. If there's no reimbursement, it will never happen, no matter how essential it is, right? Right, which is the problem with our healthcare system. I'll stop my share.
I think just looking at those pictures, you're seeing what he can create as an artist during this, but if you just take a minute to reflect on what he and his family was experiencing, because as you get further down the trajectory of the illness, his ability to really capture what was going on, yeah, it's reflected in his physical symptoms, but I wonder what the experiences was like for his family during that time.
Right. Yeah, it's having to go through something like that is just heartbreaking, and it's a little window into what a patient might be experiencing. But you're totally right. What is his family going through with all of these changes?
And can you hear me?
Yes.
This is Sky Dean. Sorry, my co-fellow and I are in the same room, and it echoes if we're both on the Zoom at the same time. Anyways, I feel like one of the things that sticks out to me most is the grieving process that family member has to go through while their loved one is still alive. And how do you cope with seeing the person that you knew in their physical body, but realize that their mind and spirit are changing, and going through and almost mourning their death before they're even gone, and then perhaps the guilt that they may feel once they are gone, because you've moved through so many stages of grief. And then how do you deal with the emotions of that person's body now being gone, but also maybe the relief you feel because both individuals are no longer suffering or walking that path. So I think there's just a lot of really difficult mixed emotions.
Yeah, no, that's such a great point, and we hear that all the time, that it's like prolonged grieving, right? When you have somebody who has dementia, it's the grief at the moment of diagnosis, it's grief at every single change and loss that they experience during that whole period of time. And I think, sometimes just acknowledging that it is this prolonged, because I think a lot of times people will tell me, like, oh, my family or my friends don't really understand. They feel like, oh, because my loved one is still here with me, that everything is fine. And then there's an outpouring of support when somebody dies, but a lot of that grieving and that work has already been done. So sometimes just showing our the family members that we're seeing them can be really helpful. And also, I think normalizing that, we do sometimes exploring that, right? I think you made such a good point about when somebody is experiencing that guilt, right? They've been grieving for so long, that it's mixed emotions when somebody dies, that there might be some element of relief, there might be some grief, but not to the degree that everybody's expecting of them. And that can be really hard. And so sometimes our role is being able to see that and being able to acknowledge that and just bear witness to that. That's a great comment. Somebody asked, is FAST the primary criteria used in hospice enrollment for all dementia conditions? It is a guide, right? So people can come onto hospice using the FAST scale, and you can have dementia as their primary diagnosis, but if they have other comorbidities, you have to look at the big picture. And so there are ways to sometimes have somebody enrolled onto hospice using decline in status guidelines. But the FAST scale, so if you have somebody who is earlier on, if they're not quite at FAST 7, they're earlier on, but then there is something else acute that's going on that makes us think that they've jumped through many of the stages because of what's going on, or because there's some other illness that is present that is causing their prognosis to be shorter. Then you can use other guidelines to help you make or have somebody enrolled onto hospice. So it's kind of big picture. Think of the FAST 7 scale as your sort of loose marker where somebody should be, but think about the big picture. What else is going on? And also think about prognosis in terms of if you have actually my patient that I was mentioning to you earlier, the patient's husband who thought that caregiving was going to kill him, he gave me this history of so in January, this was just a couple days ago, he said in January she was changing month to month, And then April and May, she was changing every few weeks. And then in June, she was changing every week or every 2 weeks. And then now she's changing day to day. And that is your prognosis right there, right? If somebody's changing month to month, usually we're looking, regardless of the illness, in general, that's like a good guideline to use, right? If it's month to month, somebody has months probably for their prognosis. If they're changing week to week, prognosis is probably weeks. And if they're changing day to day, then we're probably looking at a prognosis of days. So thinking about the big picture of what the trajectory is and how quickly they're progressing can be very helpful. Somebody asked about a question about disenrollment that was mentioned. Are they graduating because they improve, or it's just been a while, so goodbye? That is a great question. I wish I had so much time to answer that. I work for a not-for-profit hospice agency, and we have a few people who have stayed on for longer than 6 months with dementia. And as long as when it's time to recertify, as long as like 2 physicians still think they have a 6-month prognosis, they can stay on. But some people do improve, right? As soon as you get hospice services, we've seen that before. They have the good, we're kind of paring down some of the meds. We're kind of looking at the big picture and sort of trying to think about how we can best manage this patient from a big picture standpoint. And so there are people who graduate because they're doing better. There have been some articles recently that there are some agencies out there where, you know, they might think about disenrolling somebody just because it's been too long. You know, obviously, like hospice care, you know, you want to think that all hospice care is always good all of the time, and I wish it was, but there can be such variability between different places. So definitely do your research, see what different places in your communities are doing. You'll get a better sense of which one it is. Reviewing whether treating infections is beneficial is important upstream conversations. Absolutely, right? So trying to not make that a crisis moment decision or conversation. It is really helpful just to talk about it ahead of time, because we know that our patients with dementia, they're going to have infection, right? And then thinking about, does it make sense to still treat those infections? What is important to them? What are they looking for? What are they hoping to get out of it? And making sure we have those conversations ahead of time, because there's no right or wrong answer there. It's really dependent on what the patients and families' goals are. And so trying to figure out what that actually might be. And then think hard about interventions at more advanced stages. Absolutely, right? So like, I think sometimes we can so easily, I think the beauty of palliative care is that we can look at the big picture, right? And we are given that luxury. I think it is such a luxury, because I think when we're wearing different hats, it might be easy to just look at one organ system or one acute problem. But that is our job. Our job is to look at the big picture. So thinking about what might make sense for somebody. Yes. That article is actually one of the ones that I quote in here. That's a great article. It shows that people who have hospice actually live longer, especially for certain diagnoses, CHF, COPD, pancreatic cancer. So there's certain illnesses. That's a great article. Thank you for sharing that. So thinking about hospice not as something that is going to like shorten someone's life or kill someone, as the community often, you know, we'll have misunderstandings about, but just thinking about what it can do to actually help people. And we've seen that too, where somebody seems like they are completely appropriate for hospice, and we do some adjustments to their care, and that extra layer of support can sometimes help people have more time. So. All right. Well, thank you guys so much. It was so great to meet with you guys. Thank you for your participation. No, that's not what you really want to do, at 1 o'clock on a Thursday afternoon, but I appreciate you jumping in and sharing. Good luck with your fellowship year. You're almost a month in, so congratulations, and I hope the rest of the year goes well for you guys. All right, and thanks again, Ben. Appreciate it.
Thanks, Jensy. Appreciate you.
Guys, take care.
I put the link for the last 2 hours of the boot camp in the chat. So go take a break, stretch your legs, and see y'all 15 minutes.